Good morning, everyone. I call this meeting to order. We are meeting to conduct public hearings on Bill 175, an act to amend and repeal various acts respecting home care and community services. Today's proceedings will be available on the Legislative Assembly's website and television channel. We have the following members in the room. We have MPP John Fraser, MPP Sam Oosterhoff, MPP Donna Skelly, MPP Robin Martin, MPP Jim McDonnell. And the following members participating remotely are MPP Joel Hardin, Madame Jelena. We have MPP Christina Mitas, and we are joined via phone by MPP Teresa Armstrong. Am I missing anyone else? No? Good. We are also joined by staff from Legislative Research, Hansard, Interpretation, and Broadcast and Recording. To make sure that everyone can understand what is going on, it is important that all participants speak slowly and clearly. Please wait until I recognize you before starting to speak. Since it could take a little time for your audio and video to come up after I recognize you, please take a brief pause before beginning. As always, all comments by members and witnesses should go through the chair. Are there any questions before we begin? Good. Awesome. I welcome all the presenters for this morning for our 9 o'clock session. I will now call on Canadian Union of Public Employees. You will have 7 minutes for your presentation. Please state your name for Hansard and you may begin. Thank you.
Thanks so much. My name is Candace Rennick. I'm the Secretary-Treasurer of CUPE Ontario. Joining me for the presentation this morning is Michael Hurley. Michael is the President of the Ontario Council of Hospital Unions, CUPE. Also joining us is Charlene Van Dyke. Charlene is the Chair of CUPE's Healthcare Workers Coordinating Committee. And we have a staff support, Doug Allen, from our research department, who will be leading our response during the Q&A. With over 270,000 members in Ontario, CUPE is the largest union in Canada. Over 75,000 of our members work in hospitals, long-term care facilities, home and community care, local health integration networks, and other health services. This proposed legislation will privatize healthcare services. It will weaken public oversight, remove legislative protections, and undermine home care working conditions and unleash an untested home care experiment. Really, chaos awaits. Bill 175 is permissive. It allows a laissez-faire framework for home and community care. It repeals the more detailed Home Care and Community Services Act of 1994, and it leaves most details to policy or regulation. So, for example, the Home Care Bill of Rights is not in the proposed legislation, but instead it may be put into regulation. This approach removes public accountability that comes with legislation. Regulations and policies can be changed with little to no public consultation. So one would think that in today's world, a Home Care Bill of Rights would not be removed from legislation, but that is what this bill proposes. The Ministry of Health and Long-Term Care will fund Ontario Health. Ontario Health will fund the Ontario Health Teams, the OHTs, and the health service providers, the HSPs. The OHTs and the HSPs will contract for home care. Home care providers will employ home care workers and take over LHIN coordinating care functions. This convoluted model creates an obvious conflict of interest. Home care providers will deliver the service and provide care coordination. So, for example, they will get to determine the amount of service. It really is like putting the colonel in charge of the chickens. Compounding this, home care providers are often for-profit corporations, and their focus will first be on profit rather than patients' needs. The government's plan to kill off the LHIN means that home care and community services directly provided by the LHINs are under threat of privatization. Michael?
Thank you very much for having us this morning. Private for-profit hospitals have been frozen for years, but this bill would modify the Private Hospitals Act to allow them to expand home and community care beds. Similarly, the ministry is proposing to add unlicensed residential congregate care settings as a location for home and community care services with no restrictions on for-profit operators. Instead of public hospitals, these unlicensed congregate care homes would provide rehabilitative, transitional, or other care. We have learned from the COVID-19, however, that inadequate congregate care is a fatal danger for vulnerable populations. Instead of introducing new lower levels of care, we need to develop and strengthen our best public health care. Privatization will also come with proposed regulations allowing the home care corporations to operate within hospitals. Multiple chains of command within hospitals are a recipe for miscommunication and error. Home care workers moving from one hospital to the next will also be an excellent vector for the spread of infection. Destroying the main public sector organizations in home care completes the privatization of home care begun under the last progressive conservative government in the late 1990s. However, problems followed that privatization of home care delivery. Government was forced to impose moratoriums on competitive bidding to deal with the appalling, largely privatized working conditions in this sector. Government had to directly intervene twice to improve wages. Trying everything but a public sector model, CCACs were first taken over by the province, then cut from 43 to 14, and later folded directly into the LHINs. This new restructuring completely blows up these earlier reforms. Pardon me. Each of these successive rounds of restructuring was sold as a major step forward, just like Bill 175. The reality was that the privatization was a complete failure that led to successive crises in home care. Deepening privatization now will only make matters worse. This is the wrong bill at the wrong time. Unfortunately, the government is pushing this bill forward even as the province is under emergency orders. We find the timing completely inappropriate. The COVID-19 outbreak has exposed major shortcomings in our healthcare system.
1 minute.
Thousands of long-term care staff and residents have been infected. Over 1,790 have died, and we are not through this one yet. There is an urgent need for healthcare reform, but that has nothing to do with this bill. Instead, the focus should be on stopping a second peak of COVID-19, especially in long-term care. This would mean ensuring residents in long-term care are treated in hospitals and not left to die untreated or unquarantined in understaffed or overcrowded long-term care facilities. It would mean increasing pay for workers to attract and retain staff. It would mean increasing full-time work. It would mean weekly testing. It would mean phasing out for-profit long-term care. It would mean increasing the time to care. It would not mean setting off an unrelated privatization of home care, and one that will be met with spirited resistance by the healthcare workforce. Charlene?
Thank you. Right now, 14 LHINs contract for home care services within their boundaries. Under the new
Thank
model,
you so much for your presentation, and my sincere apologies to cut you off. I will now call on Patients Canada. You will have 7 minutes for your presentation. Please state your name for Hansard, and you may begin. Thank you.
Thank you very much and good morning. My name is Francesca Grosso, and I am here as the board chair of Patients Canada, which is a charitable organization dedicated to bringing the patient voice to bear on health policy and on services that work for patients. Our community consists of thousands of people who identify as patients, and we reached out to that community prior to my presenting today. So let me start with a real patient story that directly relates to the proposed Bill 175. A frail, elderly, complex patient breaks her hip and has to get it replaced. After her surgery, the surgeon explains to the family that she needs to be placed on a wait list for a rehab bed, and she urgently needs to get out of the hospital to avoid a hospital-acquired infection. The family says, great, let's get her on that list. But the hospital then explains it has no authority to do so. She has to wait for a care coordinator from a government agency to visit and authorize the physician's orders. They are the gatekeepers of home care. Worse still, the coordinator's visits are on a first-come, first-served basis, and they're backlogged. It takes fully 4 weeks for that visit to take place to authorize what the surgeon had advised 4 weeks earlier. The patient is finally placed on the wait list. Once again, first come, first served basis, and 2 days later, that patient is diagnosed with a hospital-acquired pneumonia and is moved to ICU. This story for us shows the difference between a culture of care, a culture of priority, of urgency, versus a culture of administration, of process, of first come, first serve, of lists, of quotas, that of bureaucracy, that of government agencies. In fact, 2 Auditor General reports have concluded that patients are not well served when government agencies are involved in the direct delivery and management of their care. To the committee, my presentation thus far was taken practically verbatim from the presentation made by my predecessor, Michael Decter, the past chair of Patients Canada, 4 years ago in 2016. At that time, he presented on Bill 41 entitled Patients First. And that bill was supposed to fix home care. Yet, with pressure from vested interests, the bill continued to allow government agencies to run home care, this time the LHINs. Now, we warned at that time that unless there were bold structural changes made, it wouldn't fix a thing, and we were right. Not one of our recommendations was implemented. Here we are 4 years later, and nothing has changed, so let's start. Patient journeys are still being bottlenecked by the LHINs that are inserted between the patient and the provider. Where else, I might ask, in the system is a patient's treatment subject to approval by a government agency? Nowhere except home care. And it does not work for patients. Care coordination is still being done outside of the core care team. Where else in the system is the determination of a treatment plan subject to the dictates of a government agency? Nowhere but home care. And it doesn't work for patients. And what happens when the funder of home care also dabbles in the delivery of home care? Well, dollars are disproportionately withheld to support the funder's own activities. Services are rationed, and it doesn't work for patients. On that point, by the way, that is not Patients Canada speaking. That is the finding of the Auditor General report of 2015. So today we see a bill, 175, that with some changes holds the promise of addressing the structural issues that our recommendations spoke of in 2016. Number 1, allow care organizations to determine who should get home care. Bill 175 would permit this. However, we would ask that the legislation be amended by removing the LHINs from having any active role in that determination. Without this, the powerful forces of status quo will prevail as they did the last time. Let the responsibility, number 2, for delivering services together with patients and families, let those responsible for that coordinate them. This would allow that. Once again, we ask the legislation remove the LHINs completely from care coordination for the same reason I mentioned. And the bottlenecking. Let primary care providers and hospitals refer directly to home care services. And the bill allows for that. Prohibit the funder from siphoning funds to support some of their own care activities. On this point, the legislation is silent. And we believe this conflict of interest needs to be addressed, or it will be repeated and will recreate the same rationing. The role of government and its agencies is to oversee, to hold to account, to regulate, and to fund, but it is not to deliver care. In closing, I would just say this. We want to raise one more important concern. We've heard from some patients that during the COVID pandemic, they've received calls from the LHIN cutting their services or putting them on notice that their home care services would be cut. Some of these patients depend on those services and they have no other options. This practice is not consistent with the Premier and the Minister's message that home is the safest place, and it certainly isn't consistent with what we understand the Bill 175 to be.
1 minute.
Home care is a solution, not a problem. We ask that the LHINs immediately restore home care services. I thank the committee, and I hope you'll consider our recommendations.
Thank you very much for your presentation. I will now call on Advocacy Center for the Elderly. You will have 7 minutes for your presentation. Please state your name for Hansard, and you may begin.
Good morning. I am Graham Webb, a lawyer and the executive director of the Advocacy Center for the Elderly, a legal clinic serving low-income seniors. Ms. Mitas will present and answer questions on our behalf.
Good morning. My name is Jane Mitas, and I am a lawyer, and I'm the institutional advocate at the Advocacy Center for the Elderly. The Advocacy Center for the Elderly, known as ACE, is a legal clinic which has existed in Ontario since 1984. We take over 4,000 calls annually on individual matters on a variety of seniors' issues. We get many calls regarding home care. Examples of those issues would be inaccessibility to home care due to wait lists, insufficient care, poor quality care, staff not showing up, inconsistent staffing. And we also get a lot of calls with respect to what are presently unregulated transitional beds in a variety of types of housing. These facilities are unlicensed and there's no accountability or oversight mechanisms at the present time. We echo much of what we heard from QP this morning, and I will indicate what some of our specific issues are. Submissions have been presented to the committee. First of all, we're demanding the withdrawal of Bill 175 in its entirety. We submit that the bill, which proposes sweeping changes to Ontario's home care system, has been fast-tracked through the legislature with little or no meaningful consultation at a time when we are dealing with a pandemic which is shedding light on the problems in many sectors of our home care system. We submit that this is not the time for sweeping changes, and furthermore, it's our position that many of the changes are detrimental to those using home care. We ask that the bill be withdrawn and that the government waits until a more suitable time when we can apply the lessons learned during the pandemic to any new legislation to ensure that the lessons learned during the pandemic ensure that the home care system is truly able to meet the needs of the residents of Ontario. Should the government move forward with this legislation, we believe that there are fundamental changes that are necessary. Our written submissions detail the same, but I will review some of them this morning. First, the repeal of the Home Care and Community Services Act. The bill proposes the repeal of the Home Care and Community Services Act and moving the bulk of that statute into regulation. This would include definitions, the Bill of Rights, requirements of provider agencies, and complaints and appeal processes. We believe that these areas are all vitally important and should be enshrined in statute, as would be found in other legislation such as the Long-Term Care Homes Act. This would ensure that any future changes in such important areas of the law would have to be brought before the legislature for debate, consistent with a fair and democratic government. Secondly is the delivery models. The delivery model proposed includes care coordination being moved from the 14 LHINs to various entities such as Ontario Health Teams and other care providers. We submit that this fractured system will result in system inequity and confusion. Furthermore, these entities are not Crown agencies, unlike the LHINs, which perform those services today. That means that they would not have to undergo the same scrutiny by government, such as the watchdog as the Auditor General and the Ombudsman. We submit that despite stating that care coordinators will be not-for-profit agencies, that the fact that these entities presently have no corporate structure, and if they do, they will likely be controlled by various for-profit corporations and be not-for-profit in name only. As has been seen in this pandemic, the privatization of healthcare has not been positive, and we submit that this would not be in the interest of Ontarians. The final issue that I'd like to address is residential care. This residential congregate care is referred to mostly in the regulations and it's unclear from the bill how such entities would be set up, as there are no sections in the bill specifically dealing with them. However, it would appear that these are intended to be licensed and without any clear oversight. At the Advocacy Center for the Elderly, we receive hundreds of calls every year about people being pushed into these kinds of facilities, and we have a great deal of expertise in this, and feel that the use of these has to be done in a very specific way. While we agree that a funded level of residential care is required, it must be licensed, have standards, be inspected, and have oversights enshrined in legislation similar to that we see in retirement homes.
2 minutes.
And be not-for-profit. We're also concerned that these facilities will be used instead of as a care facility where people will be able to stay between a home before they require long-term care, that instead they'll be going to be used as transitional care to move ALC patients out of hospitals while waiting placement in long-term care. Residential care cannot be used in this way. Our experience has exposed a variety of issues in this type of congregate care and use as transitional care. And our experience is that people are pressured to move from hospitals into these facilities that cannot meet their needs, and that they cannot meet the needs of these people because they require long-term care. These must be used only for people who require some level of care, less than long-term care, but more than what they're receiving in the home. We do not want to see these residential care models become a substitute for appropriate long-term care. I thank the committee for the ability to present this morning and would be pleased to answer any questions that you may have.
Thank you very much for your presentations to all the three presenters. I do see MPP Logan Kanapati joining us via Zoom. MPP Kanapati, can you please confirm that in fact it's you and also the city and the province you are calling from?
Yes, I'm joining from City of Markham, Ontario, Mr. Chair. Thank you.
Thank you so much. So now we are going to go to question and answer session. I'm going to start with the opposition, if I may know who's okay. So Madam Jelena.
Thank you, Chair. I would like to start with a question to Mrs. Jane Mitas, please. You made a very compelling case to withdraw Bill 175, that there was no consultation, that it is in the middle of a pandemic, that we have to learn our lessons from the pandemic. What would you say to people who say, but our home care system is broken, we have to fix it now?
Well, what I would say is that there are definitely issues with our home care system. There's no question about that. But to do that in the middle of the pandemic when our eyes are somewhere else is just totally inappropriate. This is a very complex system. It has to work together very well. It has to take into consideration all of the issues related to access, assessments, and ability to provide that care. And during a pandemic, when our eyes are on other things, is just not the time to do that.
Thank you. The next question will be for all three presenters in the order that you presented. So you've all talked about human resources issue. Either the care was delayed, was a different person, so if you were to tell me, do you think that human resources issue should be addressed in the bill? And if so, what would you like to see in the bill when it comes to human resources in our home care system? And I'll start with QP. Any one of you can answer.
Yes. There are very serious threats around human resources and labor relations issues in the bill. Almost all of it, or actually all of it, completely unaddressed. The LIN workers, for example, face in large part, the whole home and community care side face the demise of their organizations, even while they're being asked by this government to continue their work in a dedicated fashion. Their work is being transitioned piece by piece out from under them, all with no assurance that they're about their employment future, or even if by some chance they do have an employment future in the sector, that their conditions will be fair and reasonable, unlike the highly privatized home care industry, which is renowned for its poor wages and working conditions. That is the future that at best may await them. None of this is contemplated in the legislation. And while CUPE believes that this legislation is irredeemable and cannot be fixed and must be withdrawn, this problem festers. And indeed, it's a problem not just for the workers in the system, but for the system itself. How the government is apparently expecting the system to continue even while workers in the LHINs face the demise of their organizations. That is a threat for the government. We believe the government is very fearful of that and has not been forthright in explaining what the future bodes for the LHIN workers. But it is, the reality is going to sink home at some point, and without any assurances, the government is playing with fire. There's also the question of the changes that they've made around supervisors and labor relations, the appointment of supervisors and labor relations under the Act. Here, the bill introduces heavy-handed amendments to the Continuing Care Act, concerning sale of business and related employer provisions when a supervisor is appointed. That, of course, the whole act should be withdrawn, but failing removal, we would suggest changing the amendment so that the appointment of a supervisor alone shall not indicate that a sale of business or related employer argument can be made.
2 minutes.
This way, the sale of business and related employer provisions would still apply if changes were made that normally would bring those provisions into play.
Also, sorry, can you please state your name for Hansard?
Doug Allen from CUPE.
Mrs. Grosso, I had heard Michael Decter share the same patient story that you share. Anything related to human resources that you would like us to make sure exist?
Yes, so a couple of things on human resources. I'm not going to concentrate on LHIN human resources because they, in my view and in the view of most patients, do not deliver the bulk of the work. The bulk of the work are the people who are paid the lowest, and those are the personal support workers. Those are the people that are actually going into the homes. They have been forgotten. I know that there is an interest in blaming provider organizations, but I would say that one needs only to go back and to review what the Auditor General wrote in 2015 that talked about the siphoning of dollars from, at the time, the CCACs to the providers. To me, the problem is structural, and until we fix the problem, which is getting the LHINs out from in the middle, we will not be able to ensure the proper funding. That is what I'd like to see, is better funding for the PSWs and those going into the home.
Jane, if you could, you have 30 seconds.
Sure. So I think that we have to stop paying the workers piecemeal. So they should be not paid simply for, being at the home. They have to be paid for travel and include all the proper payment for that. I think we have to have quality controls within the legislation, as well as consistency. And I think that is really important. Our clients complain about different people in and out of their houses all the time. And I think that the legislation should gear the system towards.
Thank you so much. Apologies to cut you off. We are now going to move to the independent member, MPP Fraser.
Thank you very much, Chair, and thank you to all the presenters for being here this morning and for your great presentations. My first question is for the Advocacy Center for the Elderly and Jane Mitas. Good morning, Jane. And I want to say, maybe not totally appropriate, I keep running into your parents on walking down, and they always wave and say hello. So a couple times we're Jane's parents. So I want to thank you for all their work. They're very proud of you as well too. but that's not what I really wanted to say to you is we've heard very clearly that you believe this bill should be withdrawn because we seem to be in a rush to do something in the middle of a time that we're preoccupied with trying to manage a virus in our communities that puts the elderly at great risk. So having said that, would you, in terms of the Patient Bill of Rights, that should be, we agree, enshrined in legislation. Should we also be taking a look at that Patient's Bill of Rights and adding to that, updating it, making it stronger? Is that something that you would, and on top of that, are there any things that you think are kind of lacking in that Patient Bill of Rights right now that we should insert?
Well, absolutely. I think that the Bill of Rights does need to be reviewed and expanded. We saw that happen in the long-term care homes when it went from the old legislation into the Long-Term Care Homes Act. And I think that adding things like quality, expectation of quality, and that consistency would be a really good place to put it in the legislation so that people would expect consistent care in their home and expect people to provide the care and the time that they're supposed to. So for example, if you have an hour of care in your home, they should provide an hour of care, not 20 minutes and then sit there, or 20 minutes and leave. And that sort of thing could be used to expand the Bill of Rights.
Thank you. And then another point in your presentation was with regards to the accountability in care coordination is kind of being removed, and it's something that's either going to be left up to regulation, something unknown in the future. Are there other risks that are there because of the nature of the organizations that they won't be not just accountable, not accountable to legislated the ombudsman and the Auditor General as well too? Did I hear that correctly?
Yes, I think that we're going to really lose accountability because they're not going to be Crown agencies, so there's not going to have that oversight. I think that the fracturing of the system will be a really big problem. We already have a problem that the 14 LHINs, one person will go to the LHIN with the same set of issues and will get 2 hours a day, and another person will get 3 hours a day because of the inconsistencies. This will be magnified across the system. I agree that there probably is too much administration. I think that it could be streamlined, but I don't think that putting it in the hands of the providers and the Ontario health teams is the way to change it, because I don't believe that they're going to have oversight, and I can foresee problems.
Yeah, that's a concern that I have in the bill. Our family's been through 3 different journeys, both in home care and long-term care, retirement homes, a palliative journey, and seen where home care really works well and where it doesn't work, where it falls down, and there's no question about that. And the thing that concerns me most, and I can see that it concerns you, is the ability to actually appeal to a higher order when you're not getting the results that you want. So there is some level of accountability. What this bill does, and actually what the Connecting Care Act is, takes the governance and places it in downtown Toronto, essentially. There's no governance structures in the family health teams. There's no region, there's no community in care, there's no community structures. And so, I think we know that we need change, and we have to build.
2 minutes.
Thank you. I was waiting for that. And we have to build a better system. I want to go back to the same point. It's just that we seem to be in a rush right now when we're not all fully prepared to do the things that we need to do. So I don't know if there's anything else you want to add, Jane?
Well, one of the things I think that is helpful with the LHINs, for example, is that, if you have a problem with home care, yes, you can complain to the home care operator. But in general, we often have more success when we go to the LHIN care coordinator to assist in resolving some of these issues without having to necessarily go to, say, the Health Services Appeal Review Board, which is a much more complex process. So I think that, having someone that oversees that, that doesn't have a say, doesn't have any sort of skin in the game as to whether or not the person gets 1 or 2 hours. LHIN doesn't really care. It's the budgets, of course.
1 minute.
And that's the other thing. It has to be, we have to have proper budgeting here and have enough money going into home care, because that's part of the problem is that you can build the structures, but if you're not providing the right kind of funding, it's going to be a problem. But certainly I think the oversight is lacking in this legislation.
Thank you, Chair.
Thank you very much. Now we are going to move to the government side. I believe MPP Oosterhoff, you may start.
Thank you very much, Chair, and thank you to all the presenters this morning. Thank you for appearing before the committee and for all the work that you do for your respective organizations. It's very much appreciated, and I know there's a lot of feedback that we've heard this morning already and over the past day as well that will help inform our conversations as well about this legislation, which we believe moves in the right direction and, of course, serves to improve the patient experience. And really that's why we all believe that it's important that we make these modernization changes and break down some of those barriers between primary care providers and home care providers, and making sure that we can focus care around the patient. So I have a few different questions, but I want to perhaps begin by asking Ms. Francesca Grosso a couple of questions, because I think it's very important that we remember in this conversation the need that we have to support the patient. And all of us as elected members hear from many, many community members in our ridings about bad experiences that they've had, and of course good experience as well. We hear the compliments, the kudos, as well as the critiques. And so I want to just ask her, and of course the other presenters as well might have thoughts on this, but for Ms. Grosso, representing an organization speaking for patients, is the current system working? That's, I think, the fundamental issue here is we, I believe, have seen the failure of the current system, and we've seen that take place, and we know that we need to do better. And here are ways that we believe, for a variety of reasons that I can get into, but I've been told often, you have 2 ears and 1 mouth to use accordingly. And so I'm going to just ask Ms. Grosso if she can speak to the current system and whether or not that has worked for patients in the province of Ontario before I get into some of my further questions.
Thank you very much for your question. In a nutshell, no, it doesn't work at all for patients. And I've heard a number of things that I am a little bit puzzled by. The idea that the LHIN doesn't care whether you get 2 hours or 1 hour or 3 hours of care. That is absolutely not the case. They are the rationers of care. They are the ones that have a budget, and they are the ones that send the coordinators out to determine how many hours, minutes, and seconds a person can get. It is a highly rationed system, and people want more care at home. That's what people want. And the idea that we want to wait to fix it till after the pandemic, let me tell you what's happened during the pandemic, because we have not shone a light on home care. We've had people whose care has been cut by the same LHINs that are so caring about the patient. It is the LHINs that have made the phone calls to cut care from people. So that's what's happened during the pandemic. The other issue that's happened during the pandemic is that home care, and actually Andre Picard wrote about this morning, that home care in Ontario was dead last when it came to anything in terms of PPEs. They were not on the list. The LHINs were all on the list, all of the other providers. So no, it is not working. People don't have access, and they don't have access to robust services at home, which they need.
Yes, thank you very much. And I think that's a really key piece in this conversation, is recognizing where the current system has failed patients in our province and where we must do better. And one of the pieces that I think is so important in that is the conversation around technology. Of course, we are very grateful to see that we're beginning to move to a place where we remove the limits on care. We want to ensure everyone receives the care they need. But if you could speak a little bit to that change in technology. But before you do that, there's a lot of I'm going to call them accusations, but there's a lot of rumblings from certain sectors around the perceived privatization, and I say perceived because I'm wondering if you could point to a part in the bill that privatizes healthcare.
Well, I should start by saying Patients Canada does not take any ideological stance. We're not here to promote one group over another. We are a national organization. I think it's well worth mentioning that one of the biggest problems they had in Nova Scotia with regards to cases, deaths, actually came from a place called Northwood, a long-term care home that actually is a not-for-profit. There are tremendously great not-for-profits in home care. There are also some very good ones on the private side too. We don't get into that debate at all. We believe in very strong oversight, and we believe that when a dollar is given to any organization, regardless of their governance, that government does have a role in oversight. And I see no reason why the LHINs or any other government agency cannot continue in that kind of role. But care coordination is not an oversight role. It's a care role. It should belong with the care team. And there can be ample ways to have places where people can call and complain. I would argue that the Ontario health teams, if and when they get up running properly, these should be care organizations. So I won't go down the public-private route, only to say that I think there are plenty of good and bad on both sides. And the problems here are really of the system that structurally has failed.
I guess the reason I ask that is that I have yet to see the portion in the legislation that actually states that there's going to be increased privatization as a result of this. And I believe that that's misinformation, unfortunately, that has been spread about this piece of legislation. But I do think you spoke to a very important piece, and that, of course, is breaking down those barriers. And that's what our Ontario Health Team models are working towards, and that's what this legislation is working towards, breaking down the barriers that silo home care, community care, and primary.
Thank you, and apologies to cut you off. We are now going to move to the independent side. MPP Fraser.
Thank you very much, Chair. And I would just like to follow up with Ms. Grosso from Patients Canada. And thank you for your presentation and for your advocacy on behalf of patients. And as I said to Ms. Mitas a while ago, our family has experienced some of the journeys that you're talking about with regards to where things really don't work. And sometimes things really work as well, too. But when they don't work, it's not a good thing. And I guess the deep concern I have about this legislation is we are not giving ourselves the governance of this is being pulled away from communities, and it's being centered in downtown Toronto. There's no clear appeals process right now for people if they have a complaint with the new entities. There's no governance locally. And the actual organization, Ontario Health, doesn't have public meetings. They're not bound by that. So does Patients Canada have any concern about governance and your organization's ability to be able to advocate, given that these things are they're not in the bill and they're not clear?
Well, I think certainly governance is always a very, very big issue and a big concern. We see that the splintering of the care coordinators off in a government agency as a very, very bad thing, and we are looking forward to seeing them integrated with the care team. With regard to governance for patient complaints, that is something that we are concerned about. We would like to see something that would give the patient a path to complain. But we have assumed that just as the LHINs are not gone yet, there is no reason why they can't continue to have some kind of role in that regard until the Ontario health teams are properly up and running with proper governance structures. And we don't see that as something that's going to happen in a short period of time. Eventually, when they do, we would be very comfortable having the Ontario health teams as a system of care providing that governance. So we sort of see that the residual governance authority resides with the LHIN until these structures are fully, I guess, gone or moved out into the Ontario health teams.
Thank you very much for your answer. And I'd just like to direct my next question to CUPE and whoever would like to answer the question, because I know there's a number of you on the phone. I see Michael Hurley, who is from Ottawa, and Candace as well, too. How are you doing? So I just want to follow up on the patient, on the kind of things that are being put into regulation in this bill. And I understand and realize that you believe this bill should be withdrawn and not done, not withdrawn, period, but at least not done in the manner that we're doing this right now. And I fully agree. So as to my question with Ms. Mitas, in terms of the patient Bill of Rights, I understand you believe that that should be still kept inside legislation. Do you believe that we should be looking at that Bill of Rights and updating it, expanding it to include some things that are not there right now? And if anybody has any specifics, that'd be great. I'll leave it out there. I think, Michael, you got, what's that? No, I think someone's got to unmute.
Absolutely, we would favor strengthening the patient Bill of Rights, and you only have to look at the sordid experience of the residents in long-term care who were effectively prohibited from transferring to hospital while they had COVID-19, even though they were acutely ill and denied services. One of only a range of experiences of people in home care, in hospitals and stuff during this outbreak. So very much the rights of patients need to be strengthened, and they need to be strengthened to provide them with protections, including protections from the delivery of services in ways that that impact on them, in a very, very negative way. And, I would take serious exception with the the thought that there isn't an impact in terms of how care that is delivered in a privately operated way impacts people, because in fact, in this most recent outbreak, 3/4 of all the deaths occurred in privately owned and operated long-term care facilities. Those same facilities transferred to their shareholders 1.3 billion in profits just at the outset of this outbreak. It's clear that money comes from cleaning and from other services. It's clear from the Canadian Medical Association Journal's work that there's a huge impact on patient morbidity and mortality when services are delivered in a not-for-profit way, and people have a right to the best service that the system can provide, and that includes dedicating resources to them and not siphoning it off to people who are essentially operating in a parasitic way on these services. And so in this bill, the introduction of private hospitals, for example, the proliferation of the private hospitals is obviously an example of the proliferation of private services, which is going to have a significant impact and degradation on the care in rehabilitative and other services that are currently provided on a not-for-profit basis at a very high quality level by our public hospitals. And the question of capacity and access need to be addressed. They need to be there for the patients and the residents.
Thank you very much. Apologies to cut you off. We are now going to move to the government side. I believe MPP Christina Mitas, she's on the, I guess she's on the phone or Zoom, has a question. Christina, MPP Mitas. Yes, please go ahead.
Okay, and I'm just trying to start my video as well. Hi, everyone. So I'll start by saying that our independent colleague stated that he knew that we needed change, and I find it interesting that he said that, because I wonder why he and his Liberal colleagues did not make any change for 15 years. But I do have a question for both CUPE and the Advocacy Center for the Elderly. I'm wondering if you can tell me if you found a section of Bill 175 that specifically states that we are privatizing home care, and this is a strictly yes or no question.
So I think it's not a yes or no answer. There is not a section that specifically says that it's being privatized, but when you look at the makeup of the Ontario Health Group's teams, they are heavily infiltrated by the for-profit sector.
And QP?
Yes, the regulations, that discussion paper specifically look at the idea of turning care coordination over to the home care providers, which are primarily for profit. The fact that the government has removed the much of the oversight and guts of this legislation and has removed it from the from legislation into regulation at best or policy is not a strength of this legislation. It's another way that public accountability has been removed.
Hi, Doug. I'm so sorry. I just have a few minutes to ask questions, and I just have quite a few. So I just wanted to say, rather than making assumptions or discussing the strength of what we are putting forward, did you find specifically a section that says that we are privatizing home care, yes or no?
Yes, you are privatizing because
Did you find a section in Bill 175 that specifically states that we are privatizing home care, yes or no? Not based on assumptions?
It's not an assumption. It's what the government has written in its regulation policies.
Can you tell me which section that is?
It's in the government's regulations, discussion of regulations, which you have, if you had read, would clearly indicate to you that
I have indeed.
What the government is doing through the home care providers, which are largely for profit. We do not think that is the way to go.
So I will say that that you are answering but refusing to back up your answer with telling me where you have found it. And the Center for the Elderly, the Advocacy Center for the Elderly, has told us that it is not specifically in there. So I will go on with another question for QP. Are you aware that we posted the regulations on February 14th? Yes or no? You are. And did you submit any comments on the regulations within the 60-day notice period? Yes or no?
No, we did not.
Okay, thank you. I now have a question for Francesca. Michael stated that private immediately equates to a lower quality of care. As someone that is speaking to private healthcare providers, can you speak to that and provide some commentary on that?
Well, as I mentioned before, Patients Canada is not ideological. We are very agnostic when it comes to private delivery versus public delivery. I want to make a point here. It's very saddening to me to listen to a bill that is trying to transform what is wrong with home care. And it seems like every time any government of any stripe tries to make any change, it always ends up coming down to how do we do in the private sector providers, or how do we ensure that it's only private sector providers? I will remind everybody that fully 30% of all of our healthcare is delivered by private providers, not just home care, labs, diagnostics, etc. And that ratio has not changed regardless of stripe of government. So it sounds to me that this is being used to have a different argument, and one that Patients Canada is not prepared to engage in. We want a change. We want a change, and we want to see more cohesion of care coordination within the care team. We want more services. We want less administration. We want less bottlenecking. We want care to be done by care providers, and government can do all of the administration and the oversight. And how this always gets into a conversation of private versus public, to me, it is a false argument. It's a disingenuous argument, and it's not one that serves the public. I will say what I said before. The vast majority of the deaths, 90% of all the deaths taking place in the province of Nova Scotia, took place in a not-for-profit long-term care home. And I am not suggesting they did a terrible job. We all know all over the world that these centers are petri dishes, but this public-private debate does not serve the patient. 1 minute. And we weren't going to get into it.
Thank you. And would you agree with the characterization that the system we're putting forward will not be for profit, but will allow for private participation?
Yes, as it should, as it the status quo, as it always has. And I would hope that the viewpoint of the LIN or whoever is going to be the overseer will ensure that those providers, regardless of not-for-profit or private, are held to account and their feet are held over the fire to make sure the services are delivered well. That is what we want to see.
30
Great,
seconds.
thank you. Then I'll put a quick question to QP and the Center for Elderly Advocacy. Would you agree that private or public, that our number one priority should be serving the needs of the elderly?
The record shows very clearly that the privatization has led to an inferior version of.
Would you agree?
If you let me finish.
That our number one.
Please, that the number one priority is the patients.
Thank you so much. Apologies to cut you off. Now we are going to move to the opposition side. Okay, MPP Teresa Armstrong, you're on the phone. Please go ahead.
Thank you. I want to thank you to all the presenters. I know you're very passionate and dedicated to making sure that the funds that are put into care go to the front line, which is the patient services. And I think I want to ask, because some stakeholders have said they have not been consulted on Bill 175. Can the three presenters individually answer whether or not they were consulted on Bill 175?
I can answer that we were not consulted on Bill 175.
And I'm sorry, I didn't recognize your voice. Who were you?
It's the Jane Mitas from the Advocacy Center for the Elderly.
Okay, thank you. And then I think there was, Patients Canada. Were you consulted?
We were not consulted in any formal way, no. We were not consulted.
And QP, were you consulted in a formal way? Or any way?
No, we were not at all.
So I think the importance of this discussion that we're having on the committee on Bill 175 is to hear voices that weren't consulted in a very, very serious transformation in healthcare. And it's been very well articulated how important it is that the funds that we put in to patient care, healthcare, must be for care and not for profit. So I will take a stand and specifically say that when we are delivering care, all the money should not be for profit. It should be into care directly. I do not agree that a facility or agency that delivers care should be profiting from a government funded program. So I also have a question with regards to the transparency piece. We've been talking about this very passionately. If this government decides to continue down the path of allowing more doors open for the expansion of private care delivery, how strongly would you recommend that this oversight should be implemented into the bill? Can I get the first response from QP, please?
I think it's Michael Hurley who is responding.
Okay, QP Michael Hurley.
The expansion of for-profit delivery should not be permitted. The expansion of private hospitals should not be permitted. If we should have learned anything from this pandemic, it's the disaster that is the operation of for-profit services in terms of long-term care, and the expansion of those into rehabilitation, complex continuing care, and other hospital subacute aspects of hospital care. The introduction of for-profit delivery of home care services into a hospital setting, among other features of this bill, is something that we think is horrific.
Thank you. And Patient Canada, would you mind giving us your comments on that, please?
So our position is that oversight is a very, very important thing, regardless of whether it is private or public deliver of care, that all care delivery has to have extremely rigorous regulation and oversight, and a good ability for a patient to complain when things are not working out. And that goes beyond governance of organizations. So we would highly favor a rigorous ability for government to make sure, and as I said before, hold the providers' feet to account.
And Jane Mitas, please.
Yes, we would agree that it doesn't matter what kind of operator is delivering the services, that it has to have rigorous oversight. Our preference would be not to have for-profit agencies, again, taking profits out of our healthcare system, but oversight would be required no matter who is operating the home care system.
Okay, I think I've left some time for Joel, a little bit. Joel, you're next.
MPP Hardin.
Thank you very much, Chair. Friends from QP, nice to hear you this morning. Ms. Grosso, my question is for you. Who funds Patients Canada?
It's funded by donations on our website.
So is there any funding of Patients Canada by for-profit operators in home care or nursing homes?
We have been given donations in the past for events that we hold to help us hold the events, and I'm trying to think. No, I certainly not within the last 2 years have we had any.
So it's 100% citizen funded, and
yeah, it's 100% citizen funded. Okay. Yes, and
I would submit to you. Sorry, I only have 2 minutes. I would submit to you this. I heard and I take what you say very seriously. But in our city here in Ottawa, 70% of COVID-19 deaths have happened in 4 for-profit care homes. 4.
Mm-hmm.
And the people that I talked to that you mentioned very articulately, the PSWs who are on the front line delivering the care, so many of them, I have very rarely met a full-time person working in home care. And I've seen too many operators in the for-profit industries restricting sick days, restricting full-time access to shifts, restricting access to PPE. I actually think, I take your point about you believing it not being distinctionally private and public, but I think the record is very clear. The private operators have a lot to answer for. To MPP Oosterhoff and MPP Mitas, who both mentioned there's nothing in this bill that allows for privatization, I will point people again to 23.1, which specifically states that regulation will allow operators in the sector to charge upfront co-payments if it's specified in regulation. The government is asking us to trust them. I don't think I've heard on this conversation yet a lot of trust. We want the specificity of public.
Thank you so much. Apologies to cut you off. Based on this round, this is the end. Thank you to all the presenters. If I can just please request all the members to stay on. If we can exit the presenters, please. Awesome. Thank you so much. So we are going to go for a recess now. The House is sitting. We will be back at 10 to 1. Actually, the session will start at 1. But if I may request all the members who are on Zoom or via phone to please join around 10 to 1. So this way it's easy for our team over here to just quickly vet everyone. And the members who are here present in the room, if we have, I believe we have a vote this afternoon. If you can please make sure that you go ahead first in the East Lobby or West Lobby, whichever lobby you decide to vote, to just go ahead first, because it is a half an hour bell, and we just want to make sure that the members of this committee are here before or around 1 p.m. Are we good? Thank you so much, and see you all at 1.